rightfully so, but there can also be range of motion restrictions that then lead to the altered movement patterns that you're otherwise seeing. And number 3 for me is really, what are my impairments? And that's going to lead us into, on the rehab pyramid, that second/third phase, still phase 1, but second or third tier, where we're talking about range of motion or mobility. Okay, so when we're talking about mobility, one of the underlying principles that is going to be important is this concept of rotational motion, and this is also going to apply to our interventions before so rotational before linear. All right, jump into it quickly. Okay, so let's be real. Some of these citations are going to be the most dated ones that I present to you. That's because anatomy hasn't really changed in the 1990s. Right? And why do we come on to the 1990s? Because that's usually where the research really kind of started, and we started to really, if you look at the hockey stick or the J-shaped approach of PubMed, right, in shoulder and rehabilitation, and where we, I think therapists really started to make their presence known was in that. And so you're going to see some references, such as this one, which is a fundamental study of what happens when you elevate your arm overhead. So you have 3 figures. You have the arm at 45 degrees of abduction, 120, and then beyond, A, B, and C. So in normal arm movements, these 2 motions, that is abduction and external rotation, do not occur separately. They are coupled together. And you can, again, the illustrations in the 90s aren't as nice as they are today, but what they're trying to convey here is the portion of the humeral head that has articular cartilage has to be maintained in contact with the glenoid as we raise our arm overhead, right? Either you get an abutment or you get pain. Things just don't go well when you don't have frictionless surface articular cartilage on articular cartilage. And so as the arm elevates, it would, not only would you run out of space on the surface of the cartilage relative to the glenoid, but you also would abut the humeral head. And I've kind of tried to lay it out here. So glenohumeral joint in neutral rotation and abduction in the starting position is at like 45. That is what A is showing. And then as you start to elevate, greater than 75 degrees of pure abduction, 65 is allowed by the glenoid versus 10 from the upward rotation of the scapula if all things are going well. And then the greater tuberosity would otherwise abut, would abut on the superior labrum if there was no rotation. And so the axis of rotation now lies at 30 degrees above the horizontal, right? Because it's not truly, they describe like where the arm is relative to space, but then also relative to the absolute horizontal. But your glenoid is also changing simultaneously because of the upward rotation of the scapula. But what you can see in C is once you hit like 120, is that you actually get an external rotation in order for the chondral surface to maintain contact and to avoid the abutment under the coracoid. Okay, so that is my first plug, right? Thank you, Joe, in 1995. Ludwig in 2009 looked at what is they call it the obligatory rotation of the humeral head as you raise your arm overhead, right? And they looked at SAB, which is the little red dots that you see, or abduction in the scapular plane, scaption. The triangles that you see, or excuse me, the stars are going to be flexion, and the triangles are abduction. On the x-axis, you have someone going from 0 to 180 degrees. On the y-axis, you have the rotation, 0 being 0 degrees of external rotation, and then 80 degrees of external rotation. And so let's stick with the stars for a moment, because flexion, it's just single plane, and it makes sense for, I think, majority of folks. So as I go like this, my humeral head actually my humerus like rotates into it goes from approximately 15 degrees of external rotation, and then eventually gets up to around 70 degrees, give or take, depending on the individual. So it suggests that if I want to get my arm overhead, by all means, I have got to be able to rotate in the socket. So my internal and external rotation become my prerequisites to any linear movement. Not just flexion, not just abduction. I call linear happening in a single plane, so my extension, and then also my horizontal abduction. When you think about if you go back to your arthrokinematics, right? So like Newman, where you have your roll and your glide and your spin of your joint kinematics. It is I can rotate my shoulder without flexing. Right? It just spins around the axis. I cannot flex without the ball spinning in the socket. I'm sure you gave an example, and I've also had patients as well, right? Good rehab, great rehab. How do we get this? I've had a candid example. I had a post-operative patient come in to me. He's like, right, he's around that 12-week mark. He should be getting full range of motion. He was a little stiff. We actually like a little bit of stiffness in order to allow the enthesis to take, and then we can gain the range of motion back. Obviously, you don't want to be on too far in the end. Regardless, he comes back, comes in, and he's a software engineer, type A personality. He's like, I'm doing what I'm told, and I'm going to get the shoulder better. And he goes, I went to the doctor. I had my doctor's visit, and the doctor said to do this. And he goes, how many times should I do that? And I asked him, I said, how many times have you done that? He goes, I don't know, 10 times yesterday, and I was going to do it again 10 times today. And I was like, I want you to do it a negative 10 times. And then if you still want parameters, you can ask your surgeon, because I don't prescribe that type of exercise. Because it provides, why not? Because it forces an obligatory, just like you get obligatory external rotation, you get an obligatory humeral translation abutting up onto what is the subacromial tissues underneath, right? So surgeons are incredible carpenters. However, carpentry is done statically, right? And so at least at times I've found that their advice doesn't doesn't meet up with my understanding of natural joint mechanics. And that was one example. But we all have our lanes, if you will. So, okay, this brings us back to early this morning when we start to look at the unique anatomy. So what you're looking at is a rendering of the joint capsule of the shoulder. So they cut off the joint capsule, and then they looked at it. A is an external view, so you're looking on the outside. B is you're looking at the inside. And then C and D are looking at the different types of the morphology that you can have around the shoulder capsule. Right, so you can either have circular and or radial orientations. So circular are good. A combination of lines is better. What do you mean better? Why would we want more complexity within our joint capsule? Resilience, yes.
Allow for the spinning and the...
Yes.
And
A more complex structure can dissipate force more effectively, and it can also centrate the joint more effectively. I heard whispers. This is good. You guys are listening. Thanks. Yeah, this is right. So, but this gets the determination in the authors as they looked across all their different specimens of the and this is obviously just one joint capsule, but they looked at this and there was a consistent theme where there were less complex and more complex joint capsules, and those that had greater complexity had better mechanical properties. No surprise. I really like this figure. So circular and radial fibers are shown in one instance, the one on the left. And then you have cross-linking, advantageous, more complex, then the modifications of a simple pattern of collagen fiber bundles are consistent, that is consistent with radial and circular elements, to that of cross-linking in the glenohumeral joint is what you're looking at. This suggests that structural adaptations to shear stressing and loading in various and changes in direction allow for cross-linking to take place. This is 95, right? They were talking about this, of the complexity of the structure of the joint capsule, that when you add various loading and changes of direction into the joint capsule, that you, particularly, what helps with this is rotation. And I'll give you that example in a moment. Is that the variations of orientation and strength of fiber bundles may be interpreted as an example of an individual variations to the geometry of the joint and how someone has used that joint. So in the pinnacle image, right, where it says 0 degrees, right, we just have our radial stresses. If we want to get cross-linking, well, if we rotate in one direction, such as internal rotation, we're going to wind the capsule in the other, in one direction, and then if we want to get cross-linking of the collagen fibers, then we're going to go into external rotation. And we're going to start with this principle early on in our assessment and in our treatment, in our range of motion. So if we spoke about in multiple different directions. So right after lunch, barring a Q&A session, we're going to look at rotation here. We're going to look at it here. We're going to look at it here. Tree, spoiler alert, what your patient needs is rotation here. He doesn't need more force overhead. And the other really interesting thing is the centering of the glenohumeral joint, right? So again, Shirley Sarman, thank you for your PICR, your point of instantaneous center of rotation that she talks about with the joints, which you can see what is also illustrated, it's somewhat unique, but as you wind the joint capsule, not only do you get the collagen fiber deposition, but you get a suctioning effect, right? Look at the spacing in the top versus the spacing in the other two. Right? It has that suctioning, that centration. When you get better centration, you get better force coupling. That is, what is a force couple? It means where you have opposing forces on either side of a joint, right? And then when you have better force coupling, you're more stable. When you're more stable, you produce better force and you produce better power. And you have a better functioning shoulder.
So for overhead movement, obviously external rotation very important. Do you emphasize internal rotation as well?
I do, but you're correct. Yes, external rotation usually is more limited here than is internal. But as we saw in some of our provocation tests, if I'm limited to my internal rotation, I either am going to hike, I'm going to cervical extend, I'm going to bend my elbow, I'm going to have, if there's forces applied with that, they're not going to dissipate well if I'm already compensated.
Okay.
But you're correct, yes. It's more, and the examples that I showed suggest that as well. What I have found, and I couldn't pull the reference, but I did seek for it, is that I've also been found association between flexion being more associated with external rotation and abduction being more associated with internal rotation. All right, and then Kristen's just going to give us a little spiel on where you can find